coronary imaging versus ischemia detection. Initially, I was slightly disturbed to get the heading. Later on, I realized that while we are going for an investigation of coronary artery, our mindset keep it confined to the investigation only, structural disease or structural changes. But we forget that the same type of investigations are very close to that. We can have huge information regarding the ischemia detection of the disease portion of the coronary artery. For decades, coronary angiography served as the gold standard in the diagnosis of coronary artery disease and surrogate ischemia. The word surrogate ischemia is not utilized or not discovered by me. That is exactly what is the feeling amongst most of the cardiologists all over the world, that in one hand we are going for anatomical evidence of ischemia, on the other hand we should go for physiological or pharmacological involvement so far as the ischemia is concerned. The invasive indices on the left hand side, the more you go upwards, get high pressure. There is more comprehensive physiology, fractional flow reserve, resting indices, angiographic estimates, and anatomical assessment. If you find the pressure, coronary artery or systemic high, there will be pressure and flow only. On the other hand, if we go for fractional flow reserve, we know that fractional FFR, in the same procedure we can get, and the importance of FFR is well known to us, is increasing further. The resting indices, again, PDP, because in FFR or in investigations like this, where we are going to detect the difference in the proximal and distal end of a disease portion, this can be done by, apart from FFR, we can induce the difference by injecting adenosine or other hyperemic agent so that we find out the difference quite easily rather than waiting for what is going to happen. Angiographic estimates of flow, again QFR, CFR, CTP-FFR. So this FFR can be done absolutely non-invasively in CT-FFR. So all these factors come into play, all these ways and means come into play when we are going to check only the blood pressure and clinical condition of the patients. If you look at the clinical aspect of the structural disease, then we will find that we may have, you can see that white patch on the main artery. If the coronary artery disease subset, there may be pressure measurement like FFR in epicardial coronary artery disease. This FFR would help us to get the magnitude and other areas of differences in the terms of proximal and distal segment of the coronary artery disease. Mixed epicarditis and microvascular CAD, pressure and flow measurements is good for health, and FFR-ER also is to clear doubt and help us diagnose as well as look at the future aspect of the problems. There is no coronary artery disease. The patient may have symptoms or signs or symptoms of non-specific chest disease, suggesting that the areas of involvement of coronary arteries are almost at the microcircular level, and flow measurements, CFR and MMR, are also present. So these are the different clinical profile of the disease that we need to know. Now, This brings us to a very common word been used by us for years together, FFR. Regarded as the gold standard invasive coronary physiological index and used as reference against invasive and non-invasive ischemic indices. FFR was first physiological index to obtain class 1A recommendations. FFR threshold less than 0.8 in FAME studies and other studies reported significant superiority in terms of better outcome requiring coronary intervention. So it was initially in terms of coronary intervention that we wanted to know what is the FFR value so that we look forward to a better outcome. But now it is not related to outcome related to PCI as a medical treatment or as an overall assessment of the coronary arteries. FFR is used in different situations. This is an index of relative apical vessel conduction without stenosis and hyperemia. So we may have it without hyperemia, and that is PDPA, proximal and distal gradient. The cutoff value to guide revascularization within hemodynamic benefit is, as I mentioned earlier, 0.8. Numerous randomized control studies demonstrated compared to angiographic guidance, FFR guidance revascularization in chronic cardiac syndrome result in fewer major CV events. So CV events, that is complications are less, outcome is better. Now, when we talk in terms of FFR, we always inject an hyperemic solution before that so that the hyperemia is created and the gradient between the proximal and distal part of the lesion becomes more pronounced. But without creating any hyperemia, directly the FFR can be measured like IFR, instantaneous fractional flow, CT FFR, totally non-invasive FFR, NIR, near lipid near rate complex, suggesting another important risk factors that can be taken care of. PDPA, again, no hyperemic injections, only dry, proximal and distal gradients. And NHPR, no guidance related to injections. According to international revascularization, both FFR and IFR can be utilized for physiological stenosis assessment. So when we need to make an assessment of the stenosis, we should not necessarily go for FFR. We can go for IFR, which is easier, smaller, and technically less complicated. This is just to show you an algorithm as to how we can proceed. Suspected chronic coronary syndrome, it may have a NOCAD, no cardiac disease, flow reserve adenosine, endothelial functions, probable non-cardiac diagnosis. It may also have a pulse swab where the wire is looking into the different areas and giving us some idea. And finally, the epicardial coronary artery disease evaluation, epicardial and microvascular evaluations, microvascular and epicardial evaluations, all these suspicions are structurally and electrophysiologically confirmed before we go for further treatment. The comparison of physiological indices, these are some of the important figures that we should keep in mind. One who is practicing cardiology, practicing interventional cardiology, must have all this knowledge in terms of what is the figure that we should look at, what is the figure that we should try to avoid. Say for example, FFR, you all know 0.8, NHPR, non-FFR, non-injection, 0.89, epicardial stenosis severity, pressure and Doppler, 0.8, and then the other figures are there which are not yet fully established, but these are some of the suggestions. To sum up, ladies and gentlemen, chronic coronary syndrome patients need diagnosis and hemodynamic assessment like any coronary artery disease patients to provide timely and adequate treatment taking care of ischemia and assessment. As with FFR, IFR, the threshold has progressively migrated upwards from initial derivation studies. From 0.183 in the advice study to 0.86 in the clarified study, 0.89 in the defined flare study, IFR sweetheart study also to that level. So we now have more problems solved in terms of the threshold figure for the better outcome in FFR. So thank you very much for your patience hearing.